just say welcome to this members' education session, where we're going to be hearing about how routine health and data is being used to answer inequalities in Scotland. If people are watching this recording and want to take part in these as they happen, including the discussion, which we don't include in the recording, you just need to simply register as Use My Data member. It's free to join, it's free to take part, it's free to leave. Um, we get regular requests from our members who ask for these sessions to be able to talk directly to researchers who are actually using our health data in their daily work. So this is a really good opportunity to hear and speak with Tamsin Nash from the University of Edinburgh about her work looking at cancer inequalities. So I've said enough. I'll let Tamsin introduce herself and we can get cracking. Tamsin.
Thanks very much, Chris. Yeah, thanks for the nice introduction. My name's and actually thank you so much to everybody for dialing into the meeting today. It's really good to be able to speak to some real life people about what we're doing. So my name's Tamsin. I'm a medical oncology trainee at the Beatson West of Scotland Centre in Glasgow. But I'm actually out of clinic most of the time at the moment, working on my PhD, which is registered at the University of Edinburgh. So that's why there's a sort of a bit of both of the institutions involved in my project. And the title of the project is actually a bit of a mouthful, is Understanding Inequalities in Cancer Care, Data Linkage to Identify Priorities for Treatment Equity, which is difficult to say in one big long sentence, but really it's all about understanding whether there are disparities in the quality of treatment that we provide to people based on their social backgrounds and sort of situation in life. So I'm just going to share my screen so that you can all see my slides, and I'm hoping that you can see those.
Yeah, that's perfect.
Great. We've done the introduction and welcome. I'm just going to give you an outline of the project. This part should only take about sort of 10, 15 minutes. And then if possible, I'd really like to get some feedback from people attending the meeting and a bit of discussion going on as well. So, cancer in the UK in 2025 really seems to be facing a big problem in terms of inequalities in survival. Both of these diagrams come from the recent CR UK report, which was published last year, and shows differences between the most deprived and least deprived groups in society in terms of risk factors for cancer, things like smoking, obesity, participation in screening, and the way that people are diagnosed, but also people in more deprived groups presenting with cancer at a more advanced stage where it's more difficult to get the sort of ideal treatment. The incidence of cancer is higher in the most deprived groups, and survival at 5 years is quite a lot lower in the most deprived group. So we're talking about 52% of people surviving cancer for 5 years in the most deprived group, compared to 70% in the least deprived group. And we see those differences in survival across all different types of cancer, even those that don't often affect those that are more deprived. Your chances of surviving are less likely if you are more deprived, and we see them in all different parts of the UK, and actually particularly in Scotland. And this phenomenon has been well known for quite a long time and has been garnering a lot of attention in the last few years. Over the last 15 years, there's been more than 400 studies published about cancer inequalities in the UK. And it's become a sort of a bit of a priority for policy as well. So there's directives from the EU, and it's part of the Scottish Government's plan to sort of try to reduce cancer inequalities. But the thing with all of these studies and all of this attention is that a lot of the focus is on things that happen before someone actually gets diagnosed with cancer. So there's a lot of talk about reducing risk factors, reducing smoking, improving screening attendance so that cancer can be diagnosed at an earlier stage. And for me, as an oncologist that's treating cancer, that's not the part that I can do something about. What I'm really interested in is understanding whether the actual treatment that gets provided to patients after they're diagnosed is being allocated in a fair and equitable way. Of course, we always like to think that that's the case and that everybody gets the treatment that they need after they're diagnosed. But I don't think there's any escaping the fact that if there are different aspects of someone's life that have made it harder for them to get access to a diagnosis, those same factors will continue to affect their ability to get treatment at any point along their cancer journey. So that's what I really wanted to try to understand during my PhD, and it led me to develop these questions. So firstly, I want to know how big the disparities in survival from cancer are for people from different social groups, and that's not just social class, but also looking at ethnicity as well. Secondly, whether there are disparities in the quality of treatment between those different social groups. And thirdly, how much improvement would we see in cancer survival if we got rid of those disparities altogether? And so I've got some objectives. Firstly, I knew that I would need to link a lot of data, including individual level data from Scotland's 2011 census, and to link that with multiple data sets that we use routinely in healthcare, and to link those within a secure environment. I then wanted to measure survival in those different groups, and then explore some different measures of treatment quality in the data that's available to us. Then I wanted to look at variation in the quality of treatment between those groups, and then finally to model the effect on survival if we removed all of those disparities in care. So this diagram just kind of goes to show the overall map of the project. So we wanted to identify as many people as we could who had been diagnosed with cancer in the last 15 years or so from the Scottish Cancer Registry, and then link to other data sets that we use routinely in healthcare, so that we could understand more about their background and the type of treatment that they'd received, and to draw out some ways of measuring how good their quality of care had been. So we've linked that to hospital records and community prescribing records to get an idea of underlying medical conditions that they had, to information from the cancer waiting times, so that we can know how long they might have had to wait for their diagnosis and how they came to be diagnosed in the first place. National data on chemotherapy, so the types of treatment that they received after they were diagnosed. And then another data set, which is quite new, called the Quality Performance Indicator data set. And these are measures that are used across Scotland that are chosen by a kind of a panel of experts that are supposed to give an idea of whether that person's care was supported by best evidence. So they're really performance indicators. And all of these data sets have been linked to Scotland's 2011 census. And this is for patients with all types of cancer diagnosed since 2009 up until 2024. We were able to get approval to link all of that data, and I've now been sort of cleaning it and preparing it and getting it ready for use. And I'm now looking at survival between groups for the first time. And then we'll be trying to pick out some good measures of care quality from the data that I have linked, and then building in my model to look at removing inequalities after that. Because linking all of this data took quite a long time, I was able to spend some of the time that I was waiting for the data to get my teeth into what quality in cancer care actually means. So what do we mean when we say that, and what sorts of measures of quality will be available in the data that I've been able to request? So I looked at all of the different ways of measuring quality in wealthy nations like the UK, and there are some pretty strong patterns that emerged. We do it very similarly in a lot of different countries like the UK. Most of what we measure are things like what we call process measures. So that's what treatment was actually provided to a patient, whether that's surgery, time taken to have surgery, whether there were complications from the surgery, whether treatment was started within a set time frame, and whether that treatment was a sort of a evidence-based treatment, whether it was according to local guidelines. Most kind of quality frameworks do include some kind of measure of patient-centered care. There are measures of communication that are usually included, and sort of measures indicating whether patients were offered psychosocial support during their treatment, and whether they sort of were able to access shared decision making. But there were very few measures in any of the framework that I looked at that really focused on equity and reported on whether care was equal between different social groups. Something else that was clear was that there were no measures that showed someone's overall care. They were all just looking at one particular aspect of care and not a measure of care from start to finish of treatment. And finally, and I think very importantly, there were very few measures that really reflected the patient's voice. So there are no measures of sort of someone's subjective experience of their treatment. And what that means for me is that although I've tried to build in as many different data sets and indicators of care quality as I can using the routine data that's available in Scotland, I think that actually patient subjective experiences are probably going to be absent from my analysis, which is a concern. This is a bit of a technical slide, but as I move into my survival analysis, these are the different sources of data that I've been able to use. So the cancer registry is one, and that's where all of the information about the patient's cancer when it was diagnosed comes from. There's another data set which I'll be able to use to look at recurrence, so whether that cancer came back after they finished their treatment. And then the census, which will be used to define that patient's socioeconomic position, so their kind of lifetime circumstances. Ethnicity, the highest level of qualification, so that's a measure of education, and how they reported their own health in the census. And then we've got hospital records to understand what their other medical conditions might have been, as well as medicines that were prescribed to them in the community. And this slide really just shows how all of those different data sets will be pulled together to give the kind of final data set which we'll be using for analysis. After that, I'll be trying to build an overall measure of care that reflects the quality of each individual patient's treatment from start to finish. So I'll be recreating the kind of QPI data by looking at which measures of care each individual patient was eligible for, and then how many of those measures were actually met during the course of the patient's treatment. And then comparing that overall quality of care score between the different groups of patients which I defined in the last analysis. And then finally, and this is my last slide, because I know that the patient voice will probably be absent from that analysis, I've been trying hard to do as much patient and public involvement as I can. And to speak to people who are affected by cancer and people who are in some of the groups which I suspect might not be getting the best quality care. So people who are living in deprived areas and people who are in minoritized ethnic groups or migrant communities. We've done some work between the Beatson Cancer Centre and the Macmillan Volunteers with a local group, community group of migrant women in Glasgow, who were able to give us a really good sort of reciprocal knowledge exchange session where we discussed barriers to care faced by people in ethnic minorities and who are recent migrants to the UK, while signposting them to health services and giving them an update on what community services are available in the area. And this session with Use My Data is also a part of that. So I want to say a big thank you to everybody who's here today, because I'm really hopeful that we can sort of get some good discussion going about the project. So finally, my questions for you today are, firstly, I would love to have some feedback on the research questions and the design of the study. And I'd be really interested to hear people's views on linking health data sets and linking census data in particular, because of the sensitive nature of that data in general, and for the purposes of understanding inequalities in cancer care. And I'd also really like to discuss, the absence of the patient voice from the routine measures that we have, and any ideas that people have on how to sort of account for that and make up for it as I progress on through the project. That's the end of my slides, but I'm very happy to reshare and skip back if any of that was unclear. I know that some of them probably looked a bit technical. So yes, over to you.
Thank you, everybody, for taking part, for your comments. Thanks to you, Tamsin, for the time and energy. As ever, keep fighting the fight. We're all behind you. That's what Use My Data is about, to make your jobs easier in terms of using data for research. So any problems, you can always give us a shout, and
All
any
right.
of our colleagues.
Thanks.
Lovely.
And thank
Right.
you so much for coming.